There's a great deal of diversity in how we position men's health and what we say it is. So at one level, we talk about the biomedical aspects. So things related to the penis and the prostate, those sorts of issues, because anatomically they're unique to the male. So in some ways that becomes about male health. And then we often define men's health as in and around the pieces around gender and masculinity, so how we socially construct what it is to be a man. And then we get into the behaviours about how men operate and don't operate in the context of health. So there's a diversity in what we say men's health is. I think the challenge, certainly at the moment, and I would imagine over the next decade, will be to get a conversation whereby we can start to get a consensus about what men's health is, while accepting the diversity of understanding within the room. So men's health is a gender issue because it's related to how it is socially constructed to be a man. So we have a certain code of practice that we talk about within men's behaviours. So it's often around self-reliance, autonomy, stoicism. It's often gauged on sexual prowess, physical prowess. And so the way we construct those ideals about what it is to be a man have implication for how we do health and how we do illness. And so I think those sort of parameters, those ideals, really impact on what a man does. So I think it's clearly a gender issue, notwithstanding the issues around biology as well. I think that there's clear evidence that men's help seeking, men's risk taking are all implicated, in how they do their health. When we talk about gender and when we talk about sex, we often focus on differences. And I think that gives us a point of comparison. There are a number of things that are implicated in how men deal with depression. When we look at the statistics, we see that women are diagnosed with depression at twice the rate of men. And so in some ways that frames depression as an issue of women's health. And so I think that in part informs men that they might not be experiencing depression, and it bears out in their language. They often talk about being distressed or stressed or sad or angry, but not necessarily in terms of I have a depression or I feel depressed. The structures and how we talk about illness and particular diseases can also have implications for how men behave in regards to their help seeking around specific types of illnesses and diseases. So I think it's an interesting area, and that's very much implicated with gender and what we say the dominant ideals of masculinity are. It's interesting, back in the 70s we often talked about therapeutic model of care, where you would go to the hospital, you would get fixed and you would come home. And then health promotion put healthcare back in the hands of the individual and it drove it into the community. And I think we're starting to see some of the benefits of that model and some of the reactions. And men have been quite good at it. There's over 100 prostate cancer support groups that operate across Canada. They're rarely talked about, and certainly they don't attract a lot of media attention typically, but these guys do a tremendous job in supporting other men in terms of helping them make decisions around treatment for prostate cancer and in terms of educating around general health and well-being. So I do think that there's wonderful examples that are community-based, volunteer-run, that don't cost the healthcare system really anything, and advance the health of men. And so some of our professionally produced, interventions are not as successful as those. And I think we can learn a great deal from how some of those community-based, grassroots operations, enable men to do health promotion and do health in ways that we don't position as typical, but really are so effective. I think there's a few ways that our research could help healthcare professionals. One of the ways is that it might take a little bit of pressure off them if they were more fully aware of the resources that reside in the community. But I do think that we could talk about things like being aware that they co-construct gender with the patient. So certain expectations of men, of how men should be in clinical practice, how they should arrive, how they should express themselves. I think we've got to start to acknowledge some of those biases and start watching for patterns, but be willing to accept some diversity and not marginalise men within some of those consultations. I think that's really, really key, really important. I think as well, sometimes men don't fully articulate what's going on for them. One of the classics is when a man arrives in clinical practice, talks about stress and distress, but rarely talks about depression. I mean, I think we have to be willing to listen very carefully for those kind of nuanced accounts and to ask, questions that go beyond, work and get into relationships, to ask some of those questions to better understand what might be going on for men. Again, I appreciate it's difficult within the time constraints of a consultation these days, but some of those questions can actually save you time in the long run.